Hello, good morning. My name is Alan Lutz, healthcare analyst at Bank of America. Moderating this panel with me is Dr. Elsie Taveras, Chief Community Health and Health Equity Officer at MGB. This is the Innovations Advancing Community Health Equity panel. This morning we're going to hear how technology can help improve cardiometabolic conditions. We're going to hear challenges and opportunities to using technology to promote health equity. And we're going to learn post-pandemic trends in community healthcare. I'm going to pass it over to Dr. Taveras to ask the first question, and there may be time for Q&A.
Good morning, everyone, and thank you for joining us today. We are here with an amazing group of people who have operationalized how to bring solutions to bear to improve community health equity. And the conversation today is going to talk not just about digital solutions, but innovations, technologies, with a bit of a focus on cardiometabolic disease and beyond, and how we think about bringing, especially post-pandemic, how we bring innovations to improve the health of the communities that we serve. And I'm very excited to have the conversation this morning. What we will do as we go through each of the questions is have each of our speakers introduce themselves so you get a sense of the perspective that everybody brings to the conversation this morning. So we're going to start with talking a little bit and asking a few of my Mass General Brigham colleagues to tell us a little bit and share a little bit about the work that they are doing. And I'm going to start first with Rebecca and then Steve and Claire, hoping that each one of you can share a bit about the work that you each are involved in at Mass General Brigham that recognizes innovation and technology as important tools in advancing community health and health equity. Rebecca, do you want to get us started?
Sure, thanks, Elsie. So nice to see everyone this morning. Rebecca Mishuris, I am the Chief Medical Information Officer for Mass General Brigham and also a practicing primary care physician there. And we do so much within the digital realm to enable community health and health equity. I think where we have to start is understanding the population we're serving. And that, right, if you don't understand who you're serving and what their needs are, you are not going to be able to deliver the appropriate care, whether it's in the community or in the four walls of our hospital. And so one of the things that we have really been focused on over the last couple of years is doing just that, is understanding who are the patients and community members that we're serving. And that starts by asking the patients who they are. What's their race? What language do they speak? What disabilities might they have? What accommodations might they need for those disabilities? And really focusing in from that on what their social needs may be, right? What SDOH, social drivers or determinants of health, might they have and might they need resources to help with? And so what we've been doing at MGB is actually to start asking our patients that in multiple different ways, using technology to do that. So we ask patients those questions through our patient portal as they're preparing to come in for a visit. We ask patients, if they haven't answered that way, we then ask patients once they actually come to see us. It's one of the first things they get asked, because those SDOH needs are so important for the type of care that we can deliver to patients, right? Imagine someone who comes in who has a stable place to live and has a refrigerator and has food in that refrigerator and has a job to go to during the day. The type of care I might deliver to that person has to be fundamentally different from the type of care that I need to deliver to someone who is not stably housed, does not have a refrigerator, does not have food in that refrigerator, right? I have to focus on different things to achieve the same health outcomes for those two groups of patients. So if patients come to us and they haven't answered over the portal, we're then asking them when they do come to our four walls what their needs are, who they are. We do that on a tablet if a patient can do that on their own, or we ask them, right? Really importantly, if our patients can't engage with us through digital means, we still need to understand these things. And so we end up asking verbally what their needs are and taking that down into the electronic health record so that then everybody who is caring for that patient knows who they are and what their needs are and can devise appropriate care plans based on what those needs are.
Thank you, Rebecca. I think it's a fantastic point, and as we think about how you digitize the collection of this information, we can't enact solutions to improving hypertension, substance use disorder, maternal health, unless we are able to better characterize the social needs of our patients. And so being able to do that at the scale that we are doing it across Mass General Brigham is what Rebecca helps us power. Steve, I hope that you are able to also give us a bit of, sharing a little bit of the work that you are doing at Mass General Brigham.
Sure, yeah, my name is Steve Bartels. Steve Bartels, well, that's interesting. Introduction. Steve Bartels, I run what's called the Mongan Institute at Mass General Brigham, which is made up of 12 centers and about 145 faculty dedicated to doing team science, from data science to healthcare delivery science with a focus on health equity. This institute was really created to complete the translational science arc. So Mass General Brigham has been fabulous for years in basic and fundamental science and clinical trials, but really hadn't really met its potential in healthcare delivery science. So going from bench to bedside, classical translational science, we go from bench to bedside to clinic to population, and then also globally. And so we're that effector arm of healthcare delivery science, from discovery science to delivery. So why is this important? I think about three facts that always ring around in my head when I'm thinking about what we do. First of all, a number of people have noted that it takes about 7 years to implement only 14% of research findings into practice. That's a terrible return on investment. Secondly, a recent Commonwealth Fund report that was published by David Blumenthal and Joe Betancourt, former Mongan Institute faculty. We're in last place in health outcomes compared to other high-income countries at double the cost in terms of GDP proportion. And thirdly, just a recent report from the National Academy of Medicine, which is an update of a report called Unequal Treatment that was done in 2003. The 2014 report, also co-authored by a member of our faculty, basically determined and concluded that racial and ethnic inequity remains a fundamental flaw of the U.S. healthcare system. So those are three big problems. So how do we at the Mongan Institute seek to fix those sorts of things or work on those? First, we engage in team science, spanning different methods. So we believe that real innovation happens when you put a bunch of people together who are completely different in their methods. So we have people that do clinical translational epidemiology, looking at gene environment interaction. We have people that are predictive analytic, cost effectiveness scientists who predict the impact of putting new medications or new devices into entire populations in sub-Saharan Africa and figure out whether that's going to be cost effective before you do it. And then we also engage in co-designing solutions with communities and as well as patients and providers, and then engage in testing those models of care in pragmatic trials, and then implementation science where I sit. So that's number one, multiple methods. Secondly, we span multiple health conditions. We believe that that is one of the answers to thinking about science in this area. So we do work in cardiology, infectious diseases, diabetes, mental health, cancer, you name it. We have scientists working in those areas. And lastly, we span the spectrum of inequities. So we believe that simply having a specific characteristic, whether you're disabled or happen to be black or whatever, does not confer an inequity. It's the interactions of these things. So we think about, when we think about doing health equity research, we engage in work in race, ethnicity, disability, refugee and immigrant status, gender and sexual minorities, serious illness, low income, low resource, people who are unhoused or homeless, and social determinants of health. So that's, for us, that's the way we think about doing innovation, which is spanning different methods, co-designing with communities, spanning different conditions, and then spanning the spectrum of inequities. And if you're interested in learning more, we just published a report, our health equity research report, that you can find at monganinstitute.org. Happy to share more about that later.
I hope you do. It is a perfect example of one of the ways that one of the strengths of Mass General Brigham is exactly, Steve, what you mentioned, that ability to go from bench. We are an amazing research institution, but if that research doesn't translate to improving the health of our patients, of the communities that we serve, and doing exactly what you said, Steve, going from bench to bedside to community to streets. And with that, I'd love to have Claire introduce herself and talk a little bit about how we are doing that and how we bring innovation to assist with that continuum.
Sure, I'm Pierre. I'm the Vice President of Community Health Programs at Mass General Brigham. And one of the things that was and has been true to us and is a core part of our mission is that we know that our hospitals are embedded in communities, and there are people who live there who have different access to the excellent services we provide. And those come from a history of policies and investments that have excluded people for generations. And so one of the things we do every 3 years is that we actually pause, and with other hospitals, we ask our community members, what are priorities for them? What are the things you have? What are the things you need? And how can we work together? And across all of our hospitals, actually, the top 5 things were the same. It's what you'll probably anticipate: housing, economic mobility, food. Mental health was actually one of the top areas across all of the communities. And then we stopped and we look at the data, and we look at what is causing people to die earlier and what were preventable deaths. And we still have inequities right in our neighborhoods, right next to our hospitals where, we innovate every day. The excellent care we provide is not reaching everyone living there. And so we design now programs that are in the community. We go to places where people live and work, and we think about their homes, and we think about what we can do with them to help them manage and to help us be better at treating the conditions that we see. And of course, technology helps with that in 2 ways. One, it decreases an inequity. A lot of the people who are not able to come to our regular hour clinics, for example, are working, and they're working hourly wages. So if they lose a day for an appointment, they'll lose those wages. But if we're able to give them a wireless blood pressure cuff that transmits the information back to us, they keep their wages, and we get the information earlier. And from there, we can do the second thing, which is one of the things we know causes inequities. It's delay in treatment. So instead of waiting for the next appointment in 3 months, we can see right away if their blood pressures need to be adjusted. And we can have people who look like them, who speak their languages, who understand, call them or text them very quickly and say, hey, let's increase the dose. So we've been using technology a lot, and the numbers are already showing that there are great improvements.
I want to kind of follow up on what Claire talked about, Prabhat. Can you start by briefly describing your role, but then can you also talk about how can we use technology in order to bridge those gaps in care and expand access and support healthy lifestyles for different population groups?
Great, thank you, Alan. It's great to be here. Wonderful to see you. Prabhat saying I lead strategic initiatives at the Peterson Center on Healthcare and Peterson Health Technology Institute, which are nonprofit philanthropies that have deep roots in finance and the economy. So you can think about us as kind of where evidence meets markets. And what we really do is focus on, especially over this last year, looking at where there's been an enormous amount of investment in technology solutions over the last decade into areas like diabetes, musculoskeletal care platforms, hypertension, mental health. And we actually look at the solutions on market, the biggest ones that are expanding most quickly, and ask, do they work, and are they worth it? And in that context, we're very focused on, especially if technologies have a claim or a goal around health equity, we want to know, like, well, are we making progress? Do they work? Do they have the effects that are intended? And so, for instance, our first reports on diabetes solutions, looking at non-continuous glucose monitors, technologies like Livongo and Teladoc as an example. We looked at whether or not they actually have a impact, and then whether or not they're cost additive or not. And unfortunately for diabetes, we really found that through pretty extensive work that the effect is pretty marginal, if any, and then they just add cost. But it's a different story from musculoskeletal care. So as you may know, especially in working class, underserved communities, folks are in jobs that lead to disability, mobility, functional issues, and their ability to get to a physical therapist, get to an orthopedist is very difficult. And so actually having virtual access to get people on the road towards getting early intervention with physical therapy is quite impactful, both in terms of clinical and economic impact. And so, just taking a big step back, what we see is that the biggest areas of economic spending and where we're kind of moving backwards from a prevalence and epidemiology point of view, like in diabetes, hypertension in particular, there are huge opportunities that are actually first-order health equity issues. They're not kind of like these are big economic and kind of big condition areas, and then there's health equity over here. It's the same thing. And so as we build technologies and solutions, we have to ask, are they actually engaging the people that we want them to engage? Are they built to do that? Second is, are they delivering the clinical impact that they're supposed to, and how do we know? And then finally, we have to think about affordability because there are lots of trade-offs in investments, and particularly in community health. I think it's an area where we have a huge opportunity over the next decade to build and invest in things that work and are worth it. And that's really been our focus, and love to get into that as we continue our discussion.
Thank you. And Jorge, can you also give a brief introduction? And one of the things that you said really struck me in our pre-call. You talked about working at the intersection of social justice, medicine, and technology. I really love that. Can you talk about your experience with healthcare technology, what works, what doesn't work, and what you've learned?
Yeah, well, I appreciate you liking that. It's all over my personal statements, so that's good. So my name is Jorge Rodriguez. I'm a hospitalist at the Brigham, and I also do research there. My research really focuses on what gets me excited is digital inclusion. So this idea that everyone should have a fair and just opportunity to engage with and benefit from digital tools. And I think one of the ways that we've been doing that at MGB, and I think kind of picking up on a couple of threads my colleagues have mentioned, has been around how do we get to that point of like, here's this new technology, how do we engage our marginalized population with it? And from the literature, we sort of knew that having that human connection, that relationship was important. It wasn't just like, here's a device, see you later. It was like, here's a device, let me sort of get you to know how this is going to improve your healthcare. And so one of the areas that came up was digital navigation. Digital navigation is this idea that you have sort of a new team member or some role of a team member that helps kind of engage and onboard people with a new technology, whether it's a remote blood pressure cuff or a continuous glucose monitor. And so that sort of started to pick up a little bit of steam during the peak of the pandemic when we saw all these gaps in whether it was telehealth access, people guiding online to sign up for vaccine appointments. And so through that, I think MGB has been quite a leader in that space in terms of some of the digital navigations and digital navigators, actual people who can connect with a lot of marginalized communities and try to engage them and try to demonstrate perhaps like here's a new technology, this is the potential benefit for you, and here's how it's going to harness and support that relationship with your clinicians, which I think is important. And so the Digital Access Coordinator Program has sort of been a big component, which has been a wonderful collaboration with the digital folks over here, Rebecca and Elsie and the Health Guthrie folks. And so a great example how you can bring sort of the digital space, health equity space, bring them together to help address sort of like a gap. And I think there's sort of great opportunities to continue there. And that program has been great. And I think the other thing that program has allowed us to do is also just learn from our patients, right? Like as the navigators are showing people, here's the patient portal, they're able to point out like, this doesn't work for me, this isn't in my language, like what are the challenges? And that sort of allows us to learn from our community in a way where it's sort of a two-way street. We're trying to show you like, here's something potentially useful, and they're telling us, this is not useful for me, this is how you might make it useful, and I think that's been important. So I think it sort of really highlights the importance of kind of communicating and connecting with patients and helping us drive innovation from the community.
Great, and then last piece for me, Claire, same question, how do you use technology to promote health equity?
I mentioned before that we now go to our community partners and community organizations to deliver care, and sometimes we talk about inequities and we talk about numbers, but we forget that these are real lives. This is what, we have innovations, we have proven this is not, we know it works, and there are people who are not getting it, and it results in their deaths, right? And so it's an aunt who's responsible for the income in the household who dies at 52, and therefore the rest of their family is traumatized and struggling. And so for us, one of the things we realized was that we actually needed to invest in co-locating our services where people were. And we started doing that by having a mobile van that goes out to the communities and that partners with community organizations, hundreds of them. And we know today is going to be a food distribution day, our van will be there. Today there's going to be an after-school program, our van will be there. And because our van is there and because people are already there, they stop by and we check that blood pressure. And a few times we've sent people to the emergency room, which is not great, but it's better to catch it earlier because they would have gone home and things would have progressed to the point where it would be deadly. And so what we find is first the proximity of using old technologies like a van to deliver the care, but then to augment that with additional tools, wireless tools, texting, platforms for self-management, which means that a lot of the cardiometabolic diseases like diabetes and hypertension, unfortunately, they're with you every day. It's did you take that extra step? Did you change your diet in a way? Did you remember to take your medication? So how do we use tools to send small reminders that are not intrusive, but that actually help? And for those who cannot use the alerts, how do we connect them to a navigator who speaks their language and can text them or say, hey, do you want to talk on Friday? Let's talk about how things are going. So making sure that we have platforms where we can see the trends and identify early. One of the things we would love to have is that in addition to our vans being available and everywhere else, we're starting to notice that people use their phones to track their bus stops, right? When is the bus coming? If you waited for the bus, you want to know when it's coming. And so we're hoping to geomap or geolocate our vans so that they know when we're there and accessible. Moving from the van, the feedback we're getting is that some of our partners are telling us, what if you were actually here inside our walls with us? And for that, it's about shedding our identities, as in health institutions and partnering with other health institutions and saying, hey, we can actually have a physician here every Tuesday. And what would it mean for that patient or that person to know that we're there on a Saturday in their church or wherever it may be to receive the care? So we're both bringing the human-powered solutions, and we're using technology to track, coordinate, and deliver the care that we must give to people who don't have access to it.
And if I can add to what Claire said of like the combination of what we call the old technology, literally a van, with the new technology. A perfect example of this across Massachusetts was during COVID. It was really difficult to get real-time information of where were the hotspots of places where there was a high burden of COVID, where we might be able to bring vaccinations or services or navigation to treatment services. There was an amazing opportunity that we had to partner with an organization that was using wastewater surveillance and digitizing that wastewater surveillance to guide us in where to bring that mobile service to be able to bring COVID services. And that is just a perfect example of creativity in the implementation of a solution. Another example of how technology can help us in community health deliver the right care at the right time is that exact same wastewater surveillance information guiding our mobile addiction services and knowing where are the hotspots, where are people dying, where are overdoses happening across Boston, across Massachusetts, so that we in real time can match those data with being able to bring services right to at the bottom of Tobin Bridge or the Zakim Bridge, where there is a homeless encampment, where there are 3 or 4 overdoses all in one day, that we are able to actually bring kind of the old technology to be like very precise with our location. So I think it's a fantastic example of how we can blend the two solutions in that way. But one of the other things, Claire, that I picked up on what you were saying, and that I'd like to start with Steve, is thinking about the criteria and framework, not just for implementation and thinking about implementation, but evaluating whether a particular technology solution is ready for potential adoption. It's really important. I'll step back and say in community health, We are a lot of the work that we are doing, just with the example that I gave, we have to be data-driven. And as real-time as possible, that data allows us to be very precise with the solution that we bring to bear, that we enact. But I think one of the other important things is that we have to be willing to de-implement things that do not work. And that sometimes is even harder than implementing new initiatives. And so I would love, Steve, for you to get us started in thinking about what are frameworks that you use and that you have promoted in understanding what we know works, how, and evaluating what is ready for scaling.
Well, thanks for that question. As an implementation scientist, I'm kind of embarrassed to say that our field has published over 100 frameworks for implementation, which is too many. So how do I think about this? I guess the way I think about it is this merger of data science, participatory co-design, and then what actually works in terms of uptake, scalability, sustainability. So in terms of data science, I think about, what's the problem that we're trying to solve? Sometimes we develop technology solutions looking for a problem. In the domain of health equity, what are the root causes that are there? And then can we use data science in many different aspects to come up with solutions? So for example, you mentioned the COVID pandemic. We did a large project in Boston around preventing COVID mortality in people with disabilities in group homes. And we did simulation modeling in advance to think about what was going to have the most impact in terms of a variety of interventions, and then offered those potential solutions to the community to think about. What would you choose? What works best in your setting? What would be adapted to your situation? And then co-designed a solution and then worked on implementing it. I also think about work that we did years ago in delivering telehealth supported automated telehealth technologies to people with mental health conditions that have a 25 to 30 year reduced life expectancy due to cardiovascular disease, and having ready right by their bedside or by their dining room table a device that helped walk them through self-management. But that also was informed by understanding what were the causes and contributors to inequity. So this issue of data science, participatory co-design, using an equity lens for uptake, usability, scalability, and adaptability. And then thinking about how we deal with successful execution. I was influenced years ago by a book called The Other Side of Innovation by Chris Trimble and Vijay Govardhan, which talked about the fact that sometimes actually innovation in healthcare is the easy part, execution is the hard part, and that's what we often do in thinking about implementation. So there, in terms of frameworks, I think about evaluating systematically barriers and facilitators to uptake and spread. What makes things fail, what makes things sail, and documenting that through mixed methods or other sorts of approaches and observational approaches. And then using this, and then I think also thinking about different strategies that actually help with implementation. With technology, to some extent, for people with many different challenges that we work with, it's not whether there's a human, it's what sort of human, and in what way, and how much. The idea of coaches or supports or community health workers in implementation and evaluating that, and we're moving into looking at avatars as a substitute, which is really interesting. And then I think the issue of how do we implement some of these issues, and what are the metrics for success? And in implementation science, and this is not rocket science for sure, basically I think there's 5 things that people talk about that are metrics or frameworks. One is that the thing that you're implementing is pretty obviously better than usual care, which sometimes unfortunately is not that hard. But is there an effect size? Is there a difference that the organization, the clinic, or whatever can see and buys that it may have utility? Secondly, does it actually address what are patient needs that are related to that increased risk, whether it's cardiovascular risk or whatever? Is it really hitting the origins, the mechanisms that are behind the inequity or the health problem? Third, that it's adaptable, that it's agile, that it actually is able to work within the system and be adapted, whether it's for ethnicity or disability, urban setting, rural setting, that the thing can be changed without altering its active agents. Fourth, low complexity. High complexity interventions don't do well. Simple things do better for uptake and sustainment. And then finally, that it actually have low cost and have the capacity over time to sustain. So what we found so much in implementation science is putting stuff in place is hard, but it's doable. Having sustain over time, really hard. And sometimes that has to do with the adaptability of the thing, the way in which it actually can be altered over time. Darwinian theory really behind that, and adaptation results perhaps in survival of some of these technologies, and being able to be scalable, sustainable, and adaptable with a health equity lens as a metric.
So same question, Rebecca, for you, and then to Jorge, is thinking very specifically about evaluation when it comes to digital tools and technology, and what frameworks do you use in thinking about that?
So I think similarly, there are many frameworks to think about this as well. It has to start with being intentional about equity, right, though. So we actually had some of Elsie's team members come and talk to our entire digital staff, 1,700 people at Mass General Brigham, about what is equity, what does having an equity lens mean, so that they can start thinking about that in their everyday jobs as they are evaluating technologies and implementing those technologies for our care teams and our patients and our employees and our researchers are also at Mass General Brigham. So it has to start with just understanding how does equity come into the work that I'm doing on a day-to-day basis. And it's not just about the equity of actually delivering that care, but about the equity of the systems and the technologies that we put in place to facilitate the delivery of that care. So that's point one. And then I think from there, we have to then actually think about it in what we're doing in evaluating those technologies. And so every technology that we evaluate, we think about who's the end user, who is supposed to benefit from this technology, and are we doing that in an equitable way? And sometimes that means looking at the impact across racial lines, across genders, across languages, sometimes across SDOH needs, and what, demographic we're looking across really is dependent on the technology itself. So telehealth is a great example where, in the pandemic, we all had to go to almost 100% telehealth, but it was really important that we take a step back and look at whether we were actually engaging patients that needed care through that mechanism. And what we found, and Jorge did some of this research and I did as well, is that we actually were not reaching patients in an equitable way, right? Because there were whole swaths of patients who were not able to engage with those tools. If we had never looked, we would have left out entire populations from being able to access care through the pandemic. That's obviously a specific situation that we hope never to repeat. But it is that intentionality around looking for equity and outcomes from the technologies we're putting in place that is so critical. And then even as we are starting to think about AI, right, there's really kind of three levels of equity that we think about with AI. The first is, of course, the data, right? Are we drawing on representative data samples? Do we build our models on representative data samples of the patients or the community members we're trying to impact? The second is actually, do we see equitable outcomes from those technologies? And so if we're able to have an algorithm that helps identify which drug patients should be on to treat their hypertension, are we achieving equitable outcomes in hypertension control with that algorithm across races, across genders? And if we're not, we actually then need to go back and adjust the algorithm so that we do see those equitable outcomes. And then the third part of that is actually access to these technologies. And so there are organizations at this conference that are leading the way and paving the way for use of artificial intelligence and other innovative technologies. Mass General Brigham is certainly one of them. There are other organizations here who haven't even been able to start thinking about that because they're not resourced to be able to take advantage of these innovative technologies. And so as we think about deploying them, we have to think about how we actually can deploy them across the entire population in an equitable way. Sometimes that means bringing the costs down. Sometimes it means having organizations like Mass General Brigham that are able to do the initial innovative evaluation to show that there is actually an impact so that then those organizations can just implement them. They don't have to do that initial evaluation themselves. But we have to think about that kind of equity and access to the technology as well.
Yeah, I mean, I think you guys done a wonderful job. I think what I would add is, when I think about, sometimes I take a step back and put my kind of my clinician hat on, and then when I think about that, I really realize what's at that point of care, what's making that difference for me. And sometimes I think when I'm evaluating a new technology, I'm really going to that point and saying, is that going to really change what I do at the point of care? I'm seeing a patient. Is this new lab? Is this new device? Is it really going to change? And I think oftentimes when we may find, I was just talking about continuous glucose monitoring. Like some of the RCTs have shown that there's improvement in A1C, improvement in this space. But when you actually dive a little bit deeper, you find that there were high levels of high glucoses throughout the population, and clinicians weren't actually making huge changes as a result. So they were getting this data, and they were like, okay, but there were no changes being made. So I think I sort of try to take a step back and say, at that point of care, is this new technology, whatever it is it really changing the way I deliver care? And I think that's sort of where I kind of come down to, in addition to all the great stuff that these folks said.
So you took us to the point of care, and Prabjot, I want you to take us back to community and tell us how do you think about testing solutions in community? And the same question to you, the frameworks that you use and the criteria.
Well, thanks, Elsie. I think I'm just thinking about this panel, just the talent density in this local area, and to your point, Rebecca, it's incredible, and how important it is for an organization like MGB to keep on pushing forward and leading the way on this front. I just heard a few motifs that I just thought I'd just share that are, I think are part of answering this question, Elsie, which is, we heard from Claire that you need to know where people are. So you start to hear things about, geolocating technologies. I heard from Elsie talking about early real-time data. I heard about care navigation from Jorge. And Rebecca speaking about kind of evaluation along with Steve. And so, I think that what you're starting to hear are all the building blocks and motifs of what does it mean to not only evaluate and test, but also build and ensure that you're actually getting feedback as you're doing it. And so, when I listen to this conversation, I hear, we're just at the point where I think a significant amount of, concentrated investment into really moving, as we moved over the last 30 years from a hospital to a clinic, and now from a clinic to a community, it asks us to solve different problems, invest in different solutions, and start to bring together, a different set of folks who have the pieces of the puzzle. I will just strongly encourage to not kind of pull back the rigor as we enter such an important area as community health. I would hate to be part of a conversation where you say, hey, it's worked in one setting, let's just get it out there because the alternative is worse. And I think we often find out that that's not true, and that actually the work's so important that it merits a significant amount of attention, investment, rigor, evaluation, for the simple reason that the more quickly you find out what works and what doesn't, the more quickly you can move into a better solution, a better situation. And so that would be the kind of call. If community is important, which I think it's important to everybody that came to this session in this room, then so is the fast cycles, the intensity, the focus on kind of getting it right. And I think all the puzzle pieces and insights are kind of sitting around this panel. And I'm really excited to see what happens, in this community and the communities around it over the next decade.
We're going to do, with about 5 minutes left, we're going to do a quick round robin on what are the key opportunities that you think the audience should be aware of. Before we get to that though, Steve, you made one point here that getting people to use or the implementation process is the hardest point. I think that makes a ton of sense because people don't always know what's best for them. When Uber launched, everyone knows, I can get a car faster to somewhere, but managing your health using telemedicine for mental health is not always as easy to understand here. So as we look forward from here, starting with Claire, what do you think the key opportunities are that the audience should be aware of or be excited about moving forward from here?
I think for us, we're moving to clinical community care, right? Care right in the community. It's social risk informed and it's place-based. Technology can unlock and actually help support narrowing the inequities. But that can only happen if every investor, every innovator, every entrepreneur really looks at equity as a principle. You would not sell, promote, or implement a product that wasn't safe. Can you say the same thing about your product? Is it equitable? So keeping that as a lens and not as an activity would be important.
Steve?
Yeah, I'll just talk locally about something that I'm excited about. There's a couple of things. One is that we're really poised, I think, across not only the Mongan Institute, but across Mass General Brigham, to engage in a health equity, what I'd call health equity research incubator, a way of accelerating agile, adaptive science that doesn't wait for these long clinical trials that I've been doing for my entire career to figure out what works after 4 years of funded grants. We have to be much more agile, adaptive, creative, and we have all of the elements to put that together. We just have to figure out how to fund it. But having an incubator that focuses on health equity. And then the second thing I'm excited about is we're launching a certificate program in health equity data and delivery science. We believe that the next generation of researchers need to be trained differently. They need to understand health equity science. They need to understand data and delivery science in the bridge and how to do work in this area. So we're just starting our new class for this program next week with 28 new young fellows and researchers and clinicians spanning 10 different specialties, and we're excited about that.
Great. Jorge?
You know, I think the past few years, I tend to be a very quantitative person. Over the past few years, I've enjoyed some qualitative work, just going out and talking to people. So I think one of the things I'm most excited about, especially as like new technologies take off, is just going out into the communities, just learning about their perspectives of what do these two new technology means, like generative AI. What does that mean to someone who's living in our more underserved communities? Do they even know about it? So I think that's the kind of piece that gets me excited, because I think from the experience I've had so far, that's been like the most interesting piece about learning where things work, where are the pain points. So I think I'm just continuing to engage those communities in those conversations as new technologies emerge.
Great. Rebecca?
For me, I think the really exciting part is that we can actually start to use technology to decrease the inequities that we see. But we have to be really intentional about that. So when it comes to generative AI or something as simple as a van, right? As long as we are intentional about ensuring that the outcomes are equitable, we will actually see these technologies start to narrow that digital divide, start to narrow those inequities, both in healthcare outcomes and also in society that have grown up over decades. And so what I implore everybody in the room to do is to be intentional, as Claire was saying as well, right? Be intentional about having equity as part of your North Star, as part of your imperative for whatever you're doing, whether it's implementing a technology or developing a new technology, or even just as simple as developing a new process to engage patients in their care.
John?
You know, last week I was speaking with a senior person at a major national payer, and they said that they won't look at solutions for health equity unless they have engagement profiles above 2 to 3%. And I just want to tell you what a low bar that is. And it also just tells you that actually, when you're in the hospital or you're in the clinic, you don't get engagement for free, but you have people there. When you're entering in the community context, you actually have a scattered attention, and you have a lot of other demands. And so I would just say that actually, like, engagement is the major next frontier of health equity work. And I think what's so nice about it is that whatever level you are, if you're a student, if you are a person in a community, if you are a researcher, if you are a builder, if you're an administrator, you all have access to this question and the insights that kind of come from it. But that actually is the big puzzle piece that I think is really missing, and we're hearing enormous demand nationally for great solutions, great ideas, et cetera, but like engagement profiles are incredibly low. And I think that that's actually, you know, an incredible opportunity to just know that and then move forward with that in mind.
So with that, we are perfectly timed, actually. I think we are 11 seconds over. I hope you can join me in thanking our incredible panel here today. I love that analogy of puzzle pieces, because I think each and every one of you brought a perspective of how we actually approach equity and approach innovations in advancing community health equity. And again, a huge thank you to each one of you for participating this morning. Thank you.
Good.